Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hi there, I'm Lisa Stromquist, the Associate Director at Children's Healthcare Canada. So welcome to our webinar series, Spark Live. For those of you who haven't heard, after 17 years as CAPHC, we are now Children's Healthcare Canada, and our knowledge mobilization program is now called Spark. Our intent is to curate, convene, and showcase excellence from across the child and youth healthcare community to spark conversation, ideas, and action. Since we're live today, I want to remind everyone you do have the opportunity to type questions into the question box at any time. So we'll check for questions throughout the session, so please don't feel you need to wait until the end of the presentation before you start typing in your questions. And you can just go ahead and put them in as you think of them. Also, feel free to share your thoughts on Twitter, and be sure to tag us at ChildHealthCan. So today we are exploring pediatric disclosure of medical errors, saying sorry when bad stuff happens. So I think we can all agree the disclosure of medical errors in pediatrics is a pretty complex enterprise, having limited practice guidelines. So today we'll be presented with key findings from 3 studies within a program of research on pediatric disclosure of medical errors. We'll hear about the themes from a systematic review where no research was found on how children perceive medical errors and disclosure processes. Following that review, focus groups were conducted with key stakeholders, including healthcare providers, perhaps some of you online today, parents and children as well. In the third phase, hospitalized children and adolescents were interviewed for their perspectives on medical errors and preferences for disclosure. So we're very pleased to welcome our speakers today, Dr. Donna Collar and Dr. Sherry Espin. Dr. Collar is a professor within the School of Early Childhood Studies at Ryerson University and promotes children's participation in pediatric research. Her expertise lies in identifying key aspects of psychosocial care where children's perspectives on healthcare practices are explored. Dr. Espin is an associate professor in the Daphne Cockwell School of Nursing and teaches in the master's and post-diploma programs at Ryerson University. Her research is positioned within 2 broad and overlapping domains: patient safety and interprofessional education and collaboration. So you can read their more complete bios on our Knowledge Exchange Network. And right now, I just want to hand the virtual podium over to Drs. Collar and Espin.
So thank you, Lisa and Anne. This is Donna Collar. Sherry and I are very happy to be with you today and have the opportunity to share the collaborative research that we've done in this area, which is, I think, in many ways a relatively unexplored area. And so we're very glad then that you've joined us today. So to begin with any research, and particularly within a program of research, we've had a number of co-investigators and collaborators that we want to acknowledge and sincerely thank for their help along the way. And they're listed here because without them, we wouldn't have been able to execute the amount of research that we've been able to do. So thank you. And here's a photo of Sherry and I that we felt compelled to share. I'm not sure why, but we did. So moving right along, in terms of today's agenda, we want to begin by I think, telling a bit of a story in terms of a historical relevance piece around the hospitalized child. And then Sherry, given her expertise, is going to be talking a little bit more about definitions and concepts that are both emerging in patient safety and what might be important for us to know about at this stage. And we're going to do just a really brief overview of some of the current policies with a particular focus on Canadian experiences and policies. And then we're going to do a brief overview again of 3 studies that we've done in this area. And hopefully the goal there is to simply highlight the key features and the findings so that you can access them easily. And then to close, we will have an opportunity to talk a little bit about what we believe would be important for future research, as well as potential implications for practice and policy development. And within that, we do have one poll, and we of course welcome as many participants as possible to participate in the poll. And at the end of the webinar, we also hope to hear your questions and your comments in regards to what we've discussed. So moving right along, I want to start again, as I mentioned, to just sort of give us a minute or so just to reflect on what it's like to be a young child in the hospital. And oftentimes as healthcare professionals, and I know this because I've worked in 3 different children's hospitals, just the degree of busyness, the stressful environment, the amount of noise and stimulation that goes on, particularly in teaching hospitals, the amount of people that you have to meet, and this, it does not get lost on the young child who happens to be hospitalized. And in many ways, they often can experience lonely days. If their parents are working and not able to be by their side, they have to contend with hospital sounds and smells and new faces. And this all leads to, opportunities for a variety of behaviors, including the need to self-soothe. And we know that some children do that better than others. And so why are we talking about this in the context of errors? We do think it's important to acknowledge that pediatric health care is different than adult care. And I know, Sherry and I know that we're sort of preaching to the converted in terms of why we're saying this, but I do think it merits reflection as we move on in discussing this topic. If we look more broadly at where pediatrics has come from in terms of healthcare, if you look at some of the early pediatric hospitals, and these are some photos I'm going to show in the next few slides that show the Boston Floating Hospital, which many of you may be familiar with. So back in 1894, they established this hospital that basically sailed around the harbor in Boston. And the children on board were generally the poorest of the poor. These were children that were not able sometimes to be taken care of at home, and hence had to be dropped off at what they called at the time a charity hospital, because rich families were able to take care of their children in their homes. And so what was happening at that time was children coming onto this boat, but there was a huge amount of mortality that was occurring with the infants in particular. And it was only after some follow-up research that was done that we learned that many of these infants have likely died because of the lack of psychosocial care and the separation from their caregivers. And so I'm starting with that because I want people to think about what does that mean in terms of how we currently view children and what childhood chronic illness really means, and that these things are linked to how we view children in the first place. A prevalence or a preoccupation with age and developmental stage. In many ways, this has come from a long history of developmental pediatrics, where many times consent or understanding was based purely on whether they believed the child was old enough or had achieved a certain developmental level that would allow people to engage children in healthcare. And so what we do know, though, from talking to children and from a lot of the research that's come out of the UK, is that children are much more capable, much more able to understand and engage in fairly complex issues in regards to healthcare. And some of that came out of some early studies with children who had diabetes by Priscilla Alderson in the UK, who found that even very young children had the capacity, if done appropriately, to understand what was going on with their bodies. Again, we're still left, even when we think about bioethics and some of the decision making that's done in pediatrics around some complex issues, we're still looking down on the child. So the child is still being very much assessed by their age and limited capacity. So being able to understand that many, many children, based on their experience and their understanding in healthcare, have actually achieved higher levels of ability than we often give them credit for. And so this is a concern, I think, that's also reflected in the current literature and practice and policy of how we deal with medical errors in pediatric settings. And so before we move on with that particular topic, I want to pass it over to Sherry, who is going to talk a little bit about the new definitions and concepts in this area.
Great. Thanks very much, Donna. So I'd like to highlight then some of the, as Donna suggested, some of the definitions and terminology around patient safety language broadly and disclosure more specifically. So the definitions I'm describing are drawn from the Canadian Patient Safety Institute disclosure guidelines. And many of you may be familiar with the guidelines, but for those of you that are not, the purpose of these guidelines is to support and guide healthcare providers when harm occurs in healthcare delivery. And the document aims to create new conversations about disclosure and to clarify and address how to meet the complex needs of patients and families when an event occurs. So as a place to begin, I thought I'd share with you a few words on words. And interestingly, there has been a real shift of late in the use of error within the context of disclosure. It is common in healthcare literature and certainly in research and studies to refer to the process of disclosing errors. The CPSI guidelines, though, have purposefully avoided the use of the term error. And they've done that because their belief is that error in disclosure discussions might be misunderstood or confused to mean that the care provided was substandard or negligent in some way. However, we know this is often not the case. And by focusing on provider errors, this can promote a punitive environment that really can underpin the notion of reporting. And so instead, the language of patient safety incidences acknowledges the role of the complex systems that we practice in. And as such, it addresses the causes of incidences to bring about system changes and to importantly improve patient safety. So CPSI then has addressed or adopted the International Classification for Patient Safety developed by the WHO as a framework and terminology to facilitate sharing and learning of patient safety information globally. The purpose of this framework is to really harmonize language about safety so that providers, organizations, and countries may start to classify events similarly. And while there are 48 terms and definitions in the classification framework, there are really four main terms relevant to disclosure. And CPSI encourages the use of these preferred terms for consistency and clarity, but they also recognize that organizations have reason to continue to use other terminology. In looking at patient safety incidences, they've described them as such, and that is an event or circumstance which could have resulted or did result in unnecessary harm to a patient. Harmful incident is a patient safety incident that resulted in harm to the patient, and it replaces adverse event or sentinel event. A no harm incident is a patient safety incident which reached a patient, but no discernible harm resulted. And then lastly, near miss is a patient safety incident that did not reach the patient, and replaces close call. So the diagram explains the relationship between the four terms. And it's important to note that a patient safety incident may be a harmful incident, but it doesn't have to be. In other words, for a safety incident to have occurred, a patient does not necessarily have to be harmed. However, the potential for harm to a patient or patients needs to be present. So beginning in 2008, the Ontario government has taken a number of steps to enhance the Public Hospitals Act, to make it mandatory to facilitate and analyze critical incidences, to implement strategies, in addition to disclosing incidences to patients, hospital administrators, and the MAC. As well, Accreditation Canada has made patient safety incident disclosure a required organizational practice within the safety culture section of standards. And within the CPSI guidelines, it is stated that there are currently no formal legislation to explicitly address disclosure in pediatrics. And thus recommendations for disclosure are therefore usually extrapolated from those addressing consent to treatment. So in other words, if the child is capable enough to make a decision about his or her treatment, he or she is similarly capable of being told about a patient safety incident. However, although children or adolescents may find disclosure information upsetting or beyond their comprehension, many still have a keen interest in what happens to their bodies. As such, they should be given appropriate information having regard to age, comprehension, and emotional maturity so that they may understand their situation. And they also state within the guidelines that parents also want to hear about events in where their child was harmed. They want to know what's happened to their child, the consequences, and what is being done to prevent similar incidences from happening to another child. So examples from international policy and legislation show that some nations have specific recommendations, however, for pediatric disclosure. For example, the UK's National Patient Safety Agency policy, being open, contains specific language pertaining to pediatrics. It outlines that while patients who have attained legal age of maturity give consent to treatment, younger children are capable of understanding and can also give consent and be involved directly in disclosure discussions. Similarly, the Australian Open Disclosure Framework states that the clinical team should assess the involvement of young people in the open disclosure process on a case-by-case basis, taking into account whether the child is mature enough to receive information and having regard for the wishes of the young person and the parents where appropriate. And in the United States, recent disclosure guidelines as outlined in Safe Practices for Better Healthcare suggest that patient and, as appropriate, family should receive timely, transparent, and clear information regarding an adverse event, but does not include any specific recommendations for pediatric disclosure practices. So given the complexities associated with pediatric disclosure and the little research that has examined disclosure, Donna is now going to share results of a systematic review that specifically address and explore this issue.
Thank you, Sherry. So in terms of moving along and providing a bit of an overview of the 3 studies, the first one that we've also published on within the Pediatric Society, the Canadian Pediatric Society Journal, is our systematic review that we briefly mentioned at the outset. And so we wanted people to participate in a bit of a poll at this stage, where we've got, these are the main themes that came out of the literature review. So lack of research on error disclosure with children, no one-size-fits-all manner of disclosing errors, the punitive culture that appears to exist in terms of physicians fearing litigation, and physicians also wanting more education on disclosure more generally, and also the tensions between parents and children's preferences around the disclosure of medical errors. So we wanted to ask you the question, which of these issues resonates with your clinical or work experience?
Right, so you can choose one or more of the options on the poll. So just go ahead and click. We'll just give a 30 seconds, 45 seconds or so for everybody to start answering. All right, so we've closed the poll and now coming in at the top, so the fear of litigation, punitive culture, got 55% of the votes. Lack of research on error disclosure was another high one at 48. And again, people were choosing multiples here, so and no one size fits all manner of disclosing was 61%, so that's the highest. Physicians wanting more education on disclosure, interestingly enough, that's the lowest one at only 16%, so that doesn't seem to be the biggest issue for this crowd here today. And the tensions between parents and children's preferences at 39%. So.
Okay, that's really helpful. Thank you, Lisa. So that sort of does mirror what the children and other stakeholders within the research have alluded to as well. And so we'll expand upon that, particularly the no one size fits all, being the major winner here out of this poll. So just moving right along, the other thing that we noticed on the systematic review was that there was an emphasis and a preoccupation with the error reporting process. So how people actually report, whether they actually report in the first place, and then what's done with some of that data. So that tended to be more of a focus than on how to actually execute a disclosure process. And of course, very little again on children. And the other piece too was that, there was another preoccupation around the inconsistency of disclosure, and how even within some of the studies with physicians, how there was a real variability as to how people perceive the need to disclose, even though this was known to be an ethical obligation. And so the next study, the second one in terms of this particular program of research, was one that Sherry and I did some extensive work on, which also resulted in a paper. And so I would like to be able to pass this on to Sherry. Just as a preamble, these were a series of focus groups that we did with children, parents, and healthcare providers.
Great. Okay, thanks very much, Donna. So as Donna suggested, we conducted a series of focus groups with 3 stakeholder groups in particular. So the participants included 27 from the Patient Safety Collaborative, so a group of physicians, nurses, and patient safety professionals. We also had a group of parents 5 actually, of children with chronic medical conditions. And lastly, from the Children's Council, we had child members from a large pediatric hospital, a group of 14. And so within that group, we conducted, within the focus groups, we had provided them, each of the 3 sets of stakeholders, themes that arose from the literature. And we revisited the sessions, providing opportunities for the folks within each of the focus groups to engage and re-engage with the concepts that arose from the literature that Donna just shared with you, and glean their insights and perspectives. So in beginning with the healthcare professional group, in terms of the results, the group noted that disclosure processes and conversations are difficult. They're hard conversations to have. And they noted that context within these disclosure conversations is important. And we need to acknowledge the specific nuances that exist for each individual event. But they also spoke to the need for a consistent process for disclosure. And as one healthcare professional noted, we need to be aware of process, such as who is involved in the disclosure and in the event itself. They spoke to the importance of follow-up. They suggested that disclosure is ongoing. It's a process that is not completed or not done unless the parents say it's done. And they spoke to parents' capacity, and that parents' own capacity to understand the patient safety incident is not always understood and not always known. And finally, they spoke to to communication, and that it is ideal to have information about communication preferences vis-a-vis patients and families at intake or at early time of hospitalization. So moving on to the Family-Centered Care Advisory Council group, or the parents, they spoke to the need for more transparency, and again, for a clear process in the discussion of disclosure. Listening, they spoke to and addressed this notion that they felt they weren't always listened to, and that perhaps they weren't necessarily valued as an information source. And they talked to the child's understanding, the issue of whose responsibility is it to assess the capacity of a child to understand an event when it occurs. And sensitivity, they spoke to the need for sensitivity training for physicians. And as one parent suggested, maybe the training of the doctors should be when to seek help when they need it. And they also spoke to this idea of secret errors. And parents discussed the prevalence of secret errors, and those are errors that they knew about, and that they're errors that weren't necessarily addressed to them or spoken to them about by healthcare professionals. So in essence, happening in secrecy. And then lastly, the Children's Council. So the children spoke to individual needs. They talked about a tailored approach that suits the needs of each individual child. And they noted that some children may not want to know about what happened and the nature of the event. Yet others specifically will want to know what happened and the facts that underpin the event. They spoke to communication, and that really is an important element of what they expected from healthcare providers when it came to care. And they spoke to communication being clear and communication that's accessible to them. And they talked about child's rights. And they said that as children, we have a right to know. They said it's our body. And when an event happens, this may have long-term implications for us. And as such, we need to know. And they also spoke to consistency in terms of the disclosure process and the messaging that comes from each healthcare professional. And then lastly, they spoke about variable views, and that ties in, I think, to what we spoke about around individual needs, and that children also and youth also have a range of views regarding the process of disclosure. So we've noted in this slide the similarities that we saw across all three groups. So each of the groups described this need for a clear process for disclosure. They talked about concerns around who discloses, and that is it not necessarily the most responsible physician, for example, but perhaps those individuals involved in the error event. They talked about context and how context is relevant around noting the individual circumstances that arise from an error event. They spoke about, as a group, the training and education is important. And they also spoke to disclosure as not being enough, that disclosure is really part of a process, that there needs to be a plan of action, that it's an iterative process, and really requires ongoing follow-up. And also, the groups noted that the parent's capacity is not always better than the child's, but rather different. And so specifically, if we looked at the similarities between the parents and the children, the notion of assessment of capacity in terms of who assesses capacity, and listening. Sometimes children and parents describe that they felt that they were not being listened to. And sensitivity, the idea that sensitive healthcare providers really ease the process. And then they ask the question as to whether you can train somebody around sensitivity. And then in terms of differences, many of these we've highlighted, but if I can draw your attention to a couple that we didn't note, one is the role of the bioethics team. The healthcare professionals really felt that this team was important for consultation around having these very difficult, complex discussions around disclosure and events. And also the stress on families, the idea that really stress we know can affect families' capacity for making decisions, especially around events that may have caused harm to their child.
I hope I'm not talking too fast. I get a bit passionate when I start talking about these things, so bear with me. So this leads us to where are we today? So we've got these disconnects between literature and practice, and what the children and the families are actually telling us about what they want in terms of disclosure. And again, still dealing with the age and developmental stages as a way of figuring out how to deal with children and how to make sense of how to talk to them about things or whether to talk to them at all in the first place. And I came across this one study that was done fairly recently, published 2016, from a group of pediatricians out of Chicago. And the question that they posed in their research was, should medical errors be disclosed to pediatric patients? So their attitudes towards error disclosure. And so they surveyed 1,200 pediatricians, which is it's a large number, a large amount of data. and basically asked them if they believed that disclosure should include pediatric patients. And we had 57% agree that pediatric patients should be considered, in contrast with 98% that believe that parents should be a part of the discussion. And I think the most disconcerting piece of this research was that they actually went back to delineating an age for the child, right? So that we could disclose errors. This is the exact quote out of the article, could disclose errors to developmentally appropriate pediatric patients at a mean age of 12.15 years old, but not below the age of 10.25. Additional literature that sort of paints the same story or paints the same picture is literature that's come out, and very, very legitimate, strong scholars that have worked in this area, whose work I have respected. And I saw this book at a bioethics conference in Seattle, and was hopeful because we were just in the process of starting up this program of research. And I saw this, what looks to me as a child on the bed, and a healthcare provider, and I think essentially a parent. And my assumption at the time was, oh, this is great. We're embarking on this field of research. This might provide some guidance around disclosure with a pediatric patient. However, the focus in this book was training physicians how to disclose. There were some guidelines in there that were, I know, extremely helpful because I read them, and they were very well founded in terms of the literature and the research, but there was no mention of how to talk to the children. So where does this leave us? We have research and scholarship in the field that's now emerging. We have new ways of looking at children, hopefully, that account for their agency, their competence, their ability to understand, and yet we're still dealing with developmental stages and age markers. And we also know that parents and children have told us that they want information, and they understand the need for nuanced approaches. So they're not saying that everybody should have the same treatment, should have the same type of disclosure. So they're understanding that it has to suit the patient and the family needs. So we're recommending that we need to do additional research with children. We need to get to the core of some of these issues. Maybe we need to challenge some of the paradigms that are consistently being used in pediatrics, which ultimately inhibits the children from participating as key stakeholders in their health. And so part of that could include, having more research on children that have actually experienced an error. And I know that that's an ethical challenge, and it may be something difficult to get through an ethics board. But if we really want to tackle this gap in our understanding and in our practice, while also challenging age-old definitions of childhood that are based on old, early pediatric practices, then we need to do the work to move this forward. And in terms, again, finally, about policy and practice, how do we link all these things that we've talked about and make it a reality, both in policy and practice? So we need to be able to understand these issues better. We need to be able to challenge some of the age-old views around how we perceive children, and always recognizing that nuance in policy, nuance in pediatrics is something that makes sense. I don't know if Sherry wants to add anything at this point, but
no, I think you've done a nice summary, Donna, in terms of just as in moving forward. As we've looked across, even internationally, we recognize that there are real gaps in relation to pediatric disclosure specifically. and that the process of exploring this gap is really just evolving and beginning. And I think that there are some great opportunities for next steps.
Okay, thank you, Sherry. So we now have some time, thankfully, for questions. So feel free to ask questions or provide comments on anything we've talked about.
Great. Thank you so much, Donna and Sherry. That was a pretty comprehensive overview of your three studies. We have a question here from Carrie, and she's just wondering what defines a hospital stay. Did you have any ambulatory patients in your interviews?
No, these were all children who were at the time hospitalized. And of course, it had several hospitalizations based on their condition.
Okay. And just a reminder for people to type their questions or their comments, or maybe share some of your experiences with the rest of the group. I'm just wondering, did you notice were there any, or out of your research, anything around sort of cultural differences? Was that something that you were able to link to any sort of, wanting disclosure or wanting to keep things from their children, or whether parents or families of different cultures had different wishes?
No, we didn't actually come across anything like that. Now, the samples, particularly with the children, were quite diverse because the hospital setting itself is quite diverse in terms of the patients and the families that are seen there. There was some research that came from Anne Matlow several years ago where she surveyed parents. And really, it was interesting because there really weren't any cultural issues that came through. There was a fair amount of similarity between parents in terms of what they wanted for their children. So that's maybe the one thing I can offer if someone is questioning that.
Yeah, that's interesting. So, and Joelle is wondering, how difficult was it to get ethical approval to conduct the study?
Is this the one with the children, I'm assuming, right?
Yeah, one with the children, yes.
Yeah, it's interesting because when we embarked on this, my first thought was this is never going to get through ethics. And surprisingly, it did. And there was very little pushback. And so I think in part it had to do with the fact that we tried to create as safe conditions as we possibly could. So we made sure that we did not choose children who had experienced an error in the past. We also wanted to make sure that the children that we were interviewing were not, very anxious children or were having a difficult time with their current hospitalization. So we did try to account for some of those variables where possible. And we also had a fairly frank discussion with the parents too, in why this research was important. And that we would do whatever we could to make sure that the children would not think that an error was going to happen to them. So through the course of the interview, we would repeat this to them. We want you to know that just because we're talking about medical errors, that we're not saying that a medical error is going to happen to you or that one has already happened. I hope that helps.
And I think it also speaks to the nature of the culture within the institution. And we might argue that perhaps 10 or more years ago, this would not have been the case. And I know even in terms of some of the adult work that I've done, a number of years ago, ethics was problematic in terms of wanting to recruit folks who had experienced an error. So I think this really demonstrates the shift that we're seeing in terms of, recognizing a patient safety culture. One that is open and transparent and, willing to have these difficult conversations.
Okay, we're just going to take one or two more questions here. So how best can a parent support this with their own children's hospital or their provincial association? The experience has been much of this is physician-led in terms of no disclosure, and all allied health professionals follow their lead and are not as independent as one would think. There seems to then be multiple professional associations and much defensiveness when a mistake is discovered by a child or parent. So that's a big box to unpack.
Yeah, I'm trying. Maybe you could just repeat that first part, because I think I lost the train of thought.
Sure. So it's really how can a parent or caregiver, how can they help to lead this sort of disclosure process and ensure that that's something that's happening in their own hospital institution, wherever their child is? Not necessarily if they've had an incident, but
right.
How do they become leaders in this?
Right. So I mean, there are patient advocacy offices in most children's hospitals. There's also family advisory boards or councils as well. You could go to them. And the other thing on an individual level is to make the conversation happen. I mean, one of the healthcare providers in our focus group study recommended that this should be a discussion at the outset, at intake, where they sort of provide some information around how things should be communicated. And it may not just be in the case of an error, it just might be how do we share information, how do we make decisions together as a team within a family-centered environment. And so that would be, I mean, some of the recommendations that I would make.
Great, thanks so much. And I think we're just getting to the top of the hour now, so this will be the last question. Okay. Are patient safety incidents more prevalent with children with acute hospital stays or with children with chronic needs? You may or may not know the answer to that one. So.
Well, the thing that I think we've learned, I guess, just as an overall statement, is that most of the errors, first of all, the errors are quite prevalent in pediatrics, and hence the importance of this issue, but that it predominantly happens with infants. And it's usually a medication-based issue. And so this, again, I think speaks to the notion of the patient as the stakeholder and the vulnerability of infants in this situation. I don't know if that's helpful, but that's sort of what I would glean from that question.
Well, actually, that's great. We have a number of questions still hanging, so I don't know if maybe I can forward them to you, Sherry and Donna, or and we can
we'd be
continue the discussion offline with some of these folks.
Yes,
sure. No, absolutely. We're happy to do that, Lisa.
Okay. So I'd just like to thank you both. This has been it's been great. The discussion clearly indicates that this is something that's on people's minds and something that we need to look further into in the research, like you suggested, and look at those policies and procedures. So I think a lot of work still ahead to do. So thank you both so much, and we look forward to hearing more as you continue this work. So just to remind everybody that we do our webinars every Wednesday at 11 a.m. Eastern Time. And we always love having this live audience. Questions and comments really enrich the discussion. So if you can't make it to the live presentations, we do have an archive of many of the sessions on our Knowledge Exchange network. So on December 12th, just a little bit of a reminder, we'll be showcasing one of the award-winning teams from the poster fair at our recent annual conference. The team from Stollery Children's Hospital in Edmonton will be joining us to talk about their research related to neonatal telehealth, improving care for critically ill neonates in rural Alberta. So thanks again for everybody for joining us today, and we hope to see you back next week. Thanks, everybody.
Thank you.